There is little doubt that the biggest challenge facing our society is the coronavirus, which causes an infectious disease. However, I wanted to talk to you about a non-infectious disease, cancer, specifically living with and beyond cancer, otherwise known as cancer survivorship. As a result of my reading over the last 3 years, I published a couple of articles and I wanted to use this video to summarize what I'd learned. What do I mean by cancer survivorship or living with and beyond cancer? Well, the definition does depend on who you do talk to. The National Cancer Institute in the United States of America suggests that this is the time from a patient's cancer diagnosis until the end of life. But many would argue that this is the time when treatment begins, or perhaps after treatment has finished. Now, why is this area important? Well, the number of people worldwide who are living with cancer is increasing because of earlier diagnosis and better treatments. In the United Kingdom, the number of people living with cancer was 2.5 million in 2015, and this is set to increase to 4 million in 2030. This is similarly reflected on the other side of the Atlantic Ocean, where the number of cancer survivors continues to increase year on year in the United States of America. Since so many people are living with cancer for much longer, many believe cancer to be a chronic disease. As with any chronic disease or long-term condition, it comes with its own set of challenges. As the photo does suggest, some of these problems might be physical, such as a scar after surgery, or fatigue long after chemotherapy has ended. However, we do know that patients do suffer from many other problems, such as psychological problems such as anxiety, depression, or even isolation. One perhaps overlooked problem is financial. This is simply because many people who have treatment for cancer are unable to return to the jobs they once performed before treatment had started. This means that many may not be able to afford food, pay rent, and may even become homeless. This is what many call financial toxicity. In order to make sense of research in this area and how to move forward, the National Cancer Research Institute joined forces with the James Lind Alliance. They talked to different stakeholders, including patients, healthcare professionals, and charities, to find out what are the most pressing research priorities at the moment. After looking at many priorities, they narrowed 26 down to 10, but it is the top priority which is the focus of this video. What are the best models for delivering long-term cancer care, including screening, diagnosing, and managing long-term side effects and late effects of cancer and its treatment? What they've alluded to is who should be involved, whether that's primary care, secondary care, or voluntary organisations, and where that care should occur. For the rest of this video, I'm going to talk about the cancer care tools used globally, the evidence base behind their use, and what we do in the United Kingdom, and how do we move forward. If we look at the cancer care tools, we broadly separate them into needs assessments and care plans. Needs assessments come in different types: holistic needs assessments and problem lists. They are similar since they are both used by healthcare professionals to ask the patient a series of questions to understand their needs and provide them with support or refer them to appropriate support services. If we look at the other tools, care plans, they consist of survivorship care plans and treatment summaries. Both needs assessments and care plans are similar in the way that they provide holistic care, but care plans are often involved in care coordination between secondary care and primary care, especially when cancer treatment in hospital has finished. If we look at needs assessments first in a bit more detail and look at the highest level of evidence from systematic reviews to try and make sense of trial results, we find that holistic needs assessments and referral to appropriate services resulted in improved symptoms for up to 1 year. But the review did highlight that perhaps researchers should look at longer-term outcomes, such as engagement with services that patients are referred to. If we look at care plans, specifically survivorship care plans and the highest level of evidence from systematic reviews, researchers found that care plans did not improve health or patient outcomes. Some of the reasons why this might be is because the trials were too different. They were for different lengths of time, compared different cancer types, and measured different outcomes. Let's take a look at what we do in the United Kingdom. We are incredibly fortunate to have a cancer care charity called Macmillan Cancer Support, which has been helping patients for 109 years. We use something called the recovery package, which is a combination of the needs assessments and care plans that I mentioned before, but there is something we haven't talked about called the cancer care review and health and well-being events. Cancer care reviews are either a telephone or face-to-face appointment between a GP or practice nurse and a patient within 6 months of their cancer diagnosis. It is there to check that the patient understands their treatment, they have sufficient support, and can access state benefits. The final component, health and well-being events, are either one-to-one or group events used to reinforce information that patients have received before, including health promotion, support, and job rehabilitation. If we look at the research again, but more broadly, both patients and primary care professionals agree that the community is the best place for cancer care. However, GPs and practice nurses need more funding and more support to provide this care. Some brilliant colleagues from the United States and Australia responded to one of the articles that we wrote and suggested that perhaps we need more guideline-driven care to support GPs and practice nurses. Perhaps communication could be better between cancer specialists, family doctors, and nurses. Local oncology and primary care teams could have group learning sessions for a few hours, perhaps every month or every few months, or even every year, so that there could be better understanding of the importance of the involvement of primary care in a patient's cancer journey. This could occur in person or virtually. I know from my own clinical practice that we rely on letters, and these letters can sometimes be delayed, and perhaps a quick email or phone call might be a bit better. The pandemic has sparked a rise in teleconferencing, and perhaps this could be used for triangular consultations between cancer specialists, family practitioners, and patients. However, we must be wary that technology is a luxury not afforded to all in our society, even in the 21st century. All these actions should increase the mutual respect and understanding of the benefits of primary care in long-term cancer care. Lastly, I must thank my supervisor and Dutch colleagues who have helped me formulate my ideas and write the articles. Thank you for watching, and stay safe.